So we're going to move on now and talk about prostate cancer. As always, the last few years, so much has happened in prostate cancer, very exciting. We have Dr. Matt Smith from the Massachusetts General Hospital and Dr. Emmanuel Antonarakis from the University of Minnesota in Minneapolis. So we're going to start out and talk about a really huge topic in oncology in general, hormonal therapy of prostate cancer. I can't wait to see the capivasertib presentation at ESMO. I was telling the audience we actually did a CME program at the AUA meeting, American Urologic Association meeting, on AKT inhibition, anticipating this presentation that's going to happen. And we had to bring in Hope Rugo to talk about the side effects of capi, because obviously outside of breast cancer is not too much experience with it, but we'll get to that in a second. So Matt, let's talk about where we are today with hormonal therapy.
Happy to do so. This is a huge topic, so I'll try to hit some highlights. So first, just worth commenting that medical androgen deprivation therapy remains a mainstay of systemic treatment for prostate cancer. This is accomplished by administration of either a GnRH agonist or an antagonist. GnRH agonists, including leuprolide and goserelin, are the most commonly administered forms of medical androgen deprivation therapy, really for two reasons. They were approved first in the 1980s, and they have convenient long-acting formulations. GnRH agonists do not have a perfect product profile. They result in a transient rise in testosterone, and with chronic administration, you achieve castrate levels of testosterone. In contrast, GnRH antagonists, newer drugs including relugolix and degarelix, achieve more rapid testosterone suppression with no transient rise or so-called flare. The HERO study informed the approval of relugolix in prostate cancer. The primary endpoint of this randomized controlled trial was testosterone suppression. As you can see on the curve on the left, relugolix achieves a more rapid T suppression with no transient increase compared to leuprolide acetate. And for the subgroup of patients who discontinued treatment after 1 year, you also achieve a more rapid testosterone recovery. So rapid on effect, rapid off effect represent some advantages of this approach. Most of the side effects profile was similar between the two treatment groups. Major adverse events, serious adverse events, and sort of typical ADT effects like hot flashes and fatigue were similar between leuprolide and relugolix. While not a primary endpoint of the study, major adverse cardiovascular events were less common in patients treated with relugolix, and there's at least a plausible mechanism why that might be true. This is the cumulative incidence of major adverse cardiovascular events showing a higher rate with leuprolide compared to relugolix. This information may inform decisions between GnRH agonists and antagonists for individual patients. It is worth noting, however, this was not a primary endpoint of the trial. This difference was based on relatively few events, 37 events in the entire study. And then lastly, this observation has not been confirmed in other studies. The PRONOUNCE study was a standalone trial specifically designed to compare the incidence of MACE for degarelix versus leuprolide acetate. That study was discontinued early because of too few events, but there was no difference between degarelix and leuprolide in that trial. Treatment intensification as initial therapy for metastatic prostate cancer is among the most important advances in our field in the last decade. This summarizes the wide range of studies that have looked at treatment intensification, first with docetaxel added to ADT, then a series of ARPI studies, and then lastly, shown in yellow, the so-called triplet trials looking at ADT, docetaxel with or without an ARPI. So one of the proximal questions is, well, which is it? Should you give docetaxel and ARPI? Well, that question's been answered in subsequent trials. This is data from STAMPEDE. It's not a randomized controlled trial, but it's looking at contemporaneously randomized patients within the STAMPEDE clinical trial program. It showed no difference in overall survival between docetaxel and abiraterone acetate, although it did show benefit for intermediate endpoints, including failure-free survival, progression-free survival, and metastasis progression-free survival. The ARASEND study evaluated so-called triplet therapy. Eligible patients with MCSPC were randomized to darolutamide or placebo. Patients in both groups received ADT and docetaxel, which was the standard of care at the time this study enrolled patients. It was a pragmatically designed trial with the primary endpoint of overall survival. Compared to the control group of ADT and docetaxel, triplet therapy with darolutamide significantly improved overall survival. Hazard ratio is 0.68. Very similar to the previous doublet trials comparing addition of an ARPI to ADT alone. Now that left kind of a hole in the field in the sense of, well, we have triplet therapy with darolutamide, what about doublet therapy with darolutamide? So in some ways it's a step back to do the ARANOTE study, but this was a global trial to address that very simple question of whether darolutamide was sort of similarly effective to other ARPIs as doublet therapy in MCSPC. So this is the design of the ARANOTE study, 2-to-1 randomization to darolutamide ADT versus placebo ADT with the primary endpoint of rPFS. So it was a positive study showing an improvement in rPFS. You can see the hazard ratio there, big treatment effect, highly statistically significant. I think most of us consider darolutamide to be best in class for safety, and that sort of general observation appears to be borne out by the safety information from ARANOTE. Really, rates of any adverse event, serious adverse events, were similar between darolutamide and placebo, and rates of treatment discontinuation due to adverse events were actually higher in placebo than in darolutamide. The EMBARK study supported the FDA approval of enzalutamide in combination with ADT, as treatment for patients with non-metastatic CSPC. The EMBARK study enrolled patients with a rising PSA after prior surgery and or radiation. It was a 3-armed study. The control group was ADT with leuprolide acetate, 2 intervention arms, enzalutamide plus leuprolide acetate, and then a 3rd arm of enzalutamide monotherapy. So there are 2 different comparisons we're looking at here. The primary endpoint was metastasis-free survival, comparing enza-leuprolide versus leuprolide alone. And then a secondary analysis was the other comparison to enzalutamide monotherapy. This was a positive study and led to FDA approval of enzalutamide in non-metastatic CSPC. Here is MFS for enzalutamide combination versus leuprolide. Big treatment effect, hazard ratio 0.42, early separation of curves, and the curves remain separated throughout the follow-up period. The secondary analysis for MFS with enzalutamide monotherapy versus leuprolide was also positive, although it was a somewhat more modest effect, hazard ratio 0.63, highly statistically significant. This is a busy slide, but good to have in your files. Enzalutamide monotherapy has different side effects than androgen deprivation therapy. It's as we know from prior studies of anti-androgen monotherapy, is associated, as well as prior studies of enza monotherapy, is associated with high rates of breast symptoms, so breast enlargement, breast tenderness, and pain, as you can see in the columns to the right. Now, one of the we needed longer follow-up to evaluate the effect of enzalutamide in this setting on overall survival. There was a press release in July showing that for the primary comparison of the enza combination versus leuprolide, it does meet the secondary endpoint with a statistically significant improvement in OS. And so we await to see the data in its complete form, but we have at least the press release confirming that. Capacisertib is an oral AKT inhibitor. There's been a lot of interest in studying this pathway in hormone-sensitive cancers, including breast cancer and prostate cancer, because the AKT-P10 pathway is commonly altered in both of these malignancies. This drug is approved in combination with fulvestrant for the treatment of adult patients with breast cancer, and the approval was based on the results of the Capitello 291 study, which I think we heard a lot about in the prior session. There's been a lot of interest in studying this pathway in prostate cancer. Prior efforts have been unsuccessful, but here's the design of the Capitello 281 program. Phase 3 study of patients with MCSPC, randomized to ADT plus abiraterone acetate, so standard of care, versus that combination plus capivasertib, with the primary endpoint of rPFS, key secondary endpoint of overall survival. We've seen a press release about almost a year ago that the combination in biomarker-selected patient, which was the enrollment group, showed a significant improvement in radiographic progression-free survival. And my understanding is we'll see more about that at ESMO in next week. So in summary, the AR pathway is the best validated target in prostate cancer. ARPIs are approved across a wide range of prostate cancer. This slide is a partial summary of those, and when we have a conclusion slide for this in a few months, or certainly next year, this list will have grown substantially. Thank you.
Thanks, Matt. And Emmanuel, I'm kind of curious, again, getting into the last thing that we're talking about. Here's what we're going to see at ESMO, incidentally. As Matt mentioned, we'll see the follow-up data with survival with EMBARK. I love that study. We're going to talk about that in a second. But also this study on capivasertib. We just talked about it in the breast cancer session. I know you were sitting back there. I'm curious, Emmanuel, how you see this playing out. Obviously, we need to see the data. But assuming it's enough to get people to want to use it, do you see urologists using capivasertib?
You know, Matthew mentioned this in passing. There have been other negative or modest results with AKT inhibitors in prostate cancer in the castration-resistant setting. Ipatasertib, for example, didn't make it despite basically meeting its primary PFS endpoint in the CRPC population. Here we have the challenge that we need to obtain a biomarker in metastatic hormone-sensitive patients, which we have not typically been doing thus far. So in addition to the PFS benefit, which I would say has to be relatively large to convince me in the absence of an OS benefit, we also need to change our own mind frames as providers and begin ordering PTEN testing, in this case with immunohistochemistry, at the beginning in order to select these patients.
Matt, what do we know about the incidence of PTEN deficiency? You know, in breast cancer, we're more thinking about PIK3 mutations, AKT. You don't hear too much about PTEN. I guess prostate, that's more dominant?
It's a common alteration in the disease. I agree with what Emmanuel said. It's really the things that have changed our practice in MCSPC have been meaningful improvements in overall survival. So whether we're willing to shift that bar to an intermediate endpoint is really going to depend on the details.
If it does, and you know, interesting, and now we're going to talk in a second about PARP inhibitors and hormone-sensitive metastatic, another reason that you're going to need a biomarker workup. But if it does turn out that it's something you want to use, how do you see it being implemented in practice? I mean, capivasertib was a challenge, a different schedule, you know, tolerability issues. We were talking about glucose intolerance with these agents. How do you see it fitting into a prostate cancer setting potentially, Matt?
Well, I think what would really move us to do the biomarker testing and consider this as an attractive option will be an overall survival benefit, right? Because there's a lot of competition, right? Like, so we can give doublet therapy with an ARPI. We can intensify with triplet therapy based on 2 trials. We have PSMA addition, which will look at the addition of PSMA lutetium.
Yeah, absolutely.
And we already have that biomarker, right? Because we're staging patients with PSMA PET-CT. So there's a lot of headwinds, a lot of competition, I guess I would say, and including a number of studies that have shown OS benefits. So it's good to have competition, and I think it could have a role, but its greatest role for capivasertib would be if there's an OS benefit.
Yeah, it is interesting how many things are going on in the hormone-sensitive metastatic space. Emmanuel, what about backing into the biochemical recurrent stage? I think you've done some work with PARP inhibitors in the M0 setting. Do you see some of these targeted effects moving even into M0 disease?
Well, I heard the tail end of the breast cancer conversation this morning with adjuvant olaparib in breast cancer. That was amazing. I think in prostate cancer, it would be a bit of a stretch at the moment. In the biochemical recurrence setting, we now have the EMBARK, which has kind of become a standard of care, so we would have to build upon that. So the backbone would have to be ADT enzalutamide plus or minus a PARP inhibitor, for example, talazoparib, and I don't think those studies have been designed.
So we'll see. Let's talk about the M0 setting, particularly the EMBARK study. To me, one of the most interesting studies in oncology. When that study came out, I was like, wow, that is really amazing. And one of the things about it, Matt, was they used intermittent endocrine therapy in that setting. And I'm kind of curious, in what situations do you use intermittent endocrine therapy, and how do you use it? And do you use, I don't know if you ever use enzalutamide alone, do you do that intermittently also?
I rarely do enzalutamide monotherapy. It just has different side effects. And this population that we're referring to, I do agree that EMBARK is extremely important and kind of analogous to our previous studies in non-metastatic CRPC. One of the criticisms of that disease space is, well, it's a disappearing population because we have better imaging. And that is true. If we could go back in time, I'd love to see PSMA PET-CT part of all the non-metastatic CRPC studies and certainly part of EMBARK. But I do think increasingly, patients who are particularly the higher risk patients enrolled in EMBARK, we'd expect to find metastatic disease in most of those patients. And then it becomes a different conversation. And if you don't find detectable disease, or you only find local disease, then you're looking about salvage local therapy. I think there's less motivation to intensify therapy in the absence of PSMA PET positive disease. And then PSMA PET commonly introduces the other question about metastasis-directed therapy in patients with one or two or few identifiable sites of metastatic disease.
Yeah, I want to get into that in a second, but Emmanuel, again, do you use intermittent endocrine therapy, and how do you do it? When do you restart it?
So I would. In the trial, they used a 9-month interval. If the PSA dropped below 0.2, they had the option of stopping and then restarting when the PSA was above 2 in the trial. So in my practice, if I have a patient with true biochemical recurrence, negative PSMA PET scan, usually those people have PSAs between 0.5 and 1.5. Again, if the doubling time is rapid, less than 9 months, and they want to be aggressive with this systemic therapies, I will often do leuprolide plus enzalutamide, stop after 9 months if the PSA is less than 0.2, and then consider restarting in the future, again with a new PSMA PET scan to look for oligometastatic disease.
So what about that situation, Matt, of the patient whose CAT scans and workup is negative, but the PSMA is positive? You already mentioned if it's localized, you consider an oligometastatic strategy. But what about if it's not localized, but the only evidence is on PSMA scan? Is that enough for you to treat?
Sure, and I think the field generalizes that to be the same as metastatic disease by conventional imaging. In practice, we don't actually have such patients because we don't do bone scan and CT first. We just do a PSMA PET-CT as a replacement. So it's a more hypothetical population than an actual population in clinical practice.
When you look back at EMBARK, if you had to guess, what fraction of people do you think would have been positive if they had done PSMAs?
More than 80%.
Wow.
And we know that from non-metastatic CRPC, where we sort of simulated that population, and you find it was almost 100% of patients have identifiable disease.
Interesting.
At a PSA above 2.
So, Emmanuel, Matt talked about relugolix and degarelix. Here are some questions we got from the attendees here. Do you use either one of these? Do you prefer one versus the other? Are situations where you would rather use relugolix? I've heard people talk about it when you're using intermittent therapy. Maybe there's a quicker rebound. What about patients with cardiovascular risk factors? How do you decide on your LHRH agonist strategy?
So for patients with existing cardiovascular disease, for example, already a prior heart attack or prior stroke, it would be a reasonable thing to consider, especially if the systemic therapy was not going to be lifelong. Because of the fast switching on and off approach with the oral relugolix. The issue becomes if you have a man like the one presented here who is going to be on hormone suppression therapy in the long term, maybe for life, we don't have excellent data thus far showing the safety of combining relugolix with the ARPI agents, and that becomes the key challenge because ADT alone is not sufficient in these patients. And so we're either going to add an ARPI agent or we're going to add chemotherapy plus an ARPI agent. And my personal comfort level to use long-term relugolix plus one of the 4 ARPI agents is really not backed up by great data.
Matt, again, this 72-year-old man, history atrial fibrillation prior and STEMI. Would you think about relugolix? Or?
No. The priority is treatment intensification. For patients I'm worried about the risk of flare, I start with degarelix, typically treat for 3 months, and then switch to a more convenient long-acting formulation of leuprolide. I think relugolix is tailor-made for patients who require short-term ADT, 6 months.
Interesting. So, Emmanuel, we've talked a little bit about enzalutamide monotherapy. I thought that was one of the cool things about the study, that they even looked at it. And even though it wasn't as good as combining with ADT, it was better than ADT alone, which was our standard of care for a long time. And are you offering it to patients? Or patients, do you believe, can you talk a little bit about what you do to protect the breast, what you see with the breast? And do you think there's better quality of life or better sexual function?
You know, before the press release about the overall survival advantage only in the ENZA ADT arm, I was offering this rarely, especially when the patient was bringing it up. If the patient was asking for a castration-sparing hormone strategy, I would often, I might say reluctantly, recommend it. In addition to the gynecomastia and the breast issues that Matthew mentioned, there is a very interesting and perhaps unexpected increased cardiovascular toxicity. So when you use an unopposed antiandrogen, you get increases in LHRH, FSH, and LH, and the FSH surge could increase risk of cardiovascular disease. And if you look at the AE table from the EMBARK study, there was about a tripling of a very low percentage of cardiovascular risk. So I think that's another reason to not do it.
So I'm curious, your perspective, Emmanuel. I think we heard from Matt that he thinks that in terms of tolerability, he has a specific preference. How do you compare the available AR pathway inhibitors, and which one do you generally utilize, or using darolutamide the way Matt does?
I think all of us were relieved that the Aeronaut study was positive for PFS and approved by the FDA. The overall survival was not significant in that trial. That study was done entirely outside the U.S. There were no U.S. patients enrolled. But I have to admit and agree with Matthew that from a tolerability perspective and from a lack of drug-drug interaction perspective, it really has become the front runner for me also.
Matt, what specifically do you think? I know early on when the data was first coming out, darolutamide, you brought up the issue of falls and sort of mental fogginess. Is that what you think is the main differentiating factor, or are there other issues?
Yeah, so if you look at in the randomized controlled trials, Aeronaut and in the study in non-metastatic CRPC, it's hard to tell placebo and drug apart, particularly for treatment discontinuation, seeing, I think, a good bar to think about that. But yeah, Daro was designed not to cross the blood-brain barrier and appears to lack CNS side effects, including greater risks for falls and fractures. That said, all the ARPIs are generally well tolerated, and rates of treatment discontinuation due to adverse events, particularly for the lutamides, is relatively low.
So, Emmanuel, here's a simple question I've been in my mind for many, many years. How do you decide whether to add docetaxel and hormone-sensitive metastatic disease? We're going to be talking about lutetium and PARP and maybe other things, and CAPI maybe in the future. But right now, how do you decide? It was interesting, Matt, when you reflected back on the STAMPEDE data, docetaxel versus abiraterone. And I remember when the pandemic hit, that was kind of the choice. And people were going with hormones because we didn't bring people into the clinic. Then we had the triplet trials evolve. But I never saw a study that showed adding docetaxel to intensified endocrine therapy was better. But I still see you guys offering it to a lot of people. So who do you offer it to, Emmanuel?
Well, Neil, you raise an excellent point, which maybe the audience has not thought about as carefully as we have, which is the triplet regimens all used the ADT and the docetaxel as the backbone, with or without the ARPI. The question that you're asking here is the opposite. You're asking, if you're starting with an ADT ARPI, should you then add a chemotherapy either upfront or wait maybe until a suboptimal response? And actually, that study has been designed and will be carried out by one of the cooperative groups, the Alliance cooperative group. So that question will be answered. Now, the bullet point there, the second one, is a little bit different even than that, because what you're asking is, should you add the chemotherapy if there's some degree of suboptimal response? We don't have data there. What I would say to you is that if there is an increase in PSA during the early course of therapy, that actually converts the patient into castration-resistant phase, and then you could certainly use docetaxel for first-line mCRPC.
But just to clarify, what kind of situation will you start out with the triplet, Emmanuel? I hear you all say you have a younger patient in good condition, but what specifically are you looking for to consider the triplet as opposed to just intensified hormone therapy, Emmanuel?
Yeah, for me it's two things. One is if the disease is high volume, more than 4 metastases, visceral metastases always concerns me, as well as what we call de novo disease, in other words, metastatic disease, synchronous presentation. And then the final thing is biomarkers. If these patients have P10, P53, or RB1 alterations, or a combination of two of those three, the response to AR inhibitor alone is going to be low, so I would add a triplet there as well.
That's interesting. Matt?
I completely agree. I take the same approach, and it is part of what motivates me to do tumor genetic testing at baseline in patients with de novo metastatic disease.
So some questions actually even before this about what we've been talking about, capivasertib. I think we already talked about a number of these things. But one question I think is interesting, Matt, do you think that the tolerability profile is going to be similar to what you see in breast cancer, or maybe different because it's men, or... and any thought also about, maybe the patients are older, more likely to have glucose intolerance, how this is going to play out?
More of the latter concern. I think we're going to be generally older patients with more comorbidities, and so I do think that the safety profile is going to be extremely important. Probably not a drug that will be routinely prescribed by urologists, except perhaps very specific urologists in large urology group practices.
All right, Emmanuel, let's talk about PARP and also lutetium. Again, things are happening quickly here.
Thank you, Neil. You gave me a complex topic, and it's going to be a little bit like speed dating, and we'll see whether you invite me back for a second date next time.
Take your time.
All right, so PARP inhibitors for HRR mutated and BRCA1/2 mutated advanced prostate cancer. First of all, when do we use these drugs? These drugs are only effective in the context of an underlying somatic or germline homologous recombination repair deficiency, such as BRCA2, BRCA1. A rule of thumb, about a quarter of patients at the somatic level, if you sequence their tumor, are going to have one of these mutations. In the germline, about 1 in 10 patients will have an inherited form of one of these gene mutations. I've come up with a list that helps me in my clinic to estimate the efficacy of PARP inhibitors, and the 5 genes on the left are the ones that I think are the most sensitive to PARP inhibition, followed on the right, third tier, with the ones that are less sensitive or insensitive, despite the fact that they're still called HRR genes. Now, in the first-line mCRPC setting, we have 3 trials adding a PARP inhibitor to a backbone of ADT plus an ARPI. In the PROPEL study, the backbone was abiraterone with or without olaparib. In the MAGNITUDE study, it was abiraterone with or without niraparib. And in the TELEPRO-2, it was enzalutamide with or without talazoparib. The subsequent FDA approvals are shown on the right, and for the top 2 trials are based on BRCA1 and BRCA2 alone, somatic or germline, and then in the TELEPRO-2 study, the approval includes 11 genes, as shown there. So all of these studies were positive. PROPEL was the first one, showing an RPFS benefit here. Interestingly, despite the RPS benefit being seen in the entire intention to treat population, the FDA and ODAC decided that this will only be approved for BRCA1 and BRCA2, where the benefit was the greatest. MAGNITUDE showed a similar thing with niraparib plus abiraterone, where the benefit in the BRCA1/2 mutated patients was much greater than in the other HRR patients, and hence again, the approval here is for BRCA1 and 2 alone. TELEPRO-2, the approval is extended to 11 genes here, and once again, the HRR deficient subset had a greater magnitude of RPFS benefit than the HRR non-deficient patients. Now, side effects here, there are some slight differences. There's a class effect with anemia and thrombocytopenia and transfusion requirement. The transfusions are a little bit more intense for the niraparib and talazoparib, less so for olaparib. Olaparib causes more nausea, as shown there in the middle. Very rare but serious AML MDS risk occurring in a handful of patients. Now this is going to be presented, this was presented at ASCO 2025 and soon to be published, the Amplitude study. So this was a metastatic hormone-sensitive disease trial. All patients got ADT plus abiraterone with or without niraparib or placebo. These were 12 HRR genes that were included, so this was an HRR mutated population. Key primary endpoint was rPFS. So the study was positive. If you look at the right-hand side, this shows the full panel of all the HRR genes, the intention to treat, significant with an upper limit of hazard ratio less than 1, but the significance in the magnitude was even greater in the BRCA1, BRCA2 patients. If you are interested in the gene-by-gene analysis, the top rows show rPFS, the bottom rows show OS. The boxes on the left are favoring the addition of niraparib. You can see a clear PFS benefit with BRCA1 and 2, and you can see an OS approaching significance for BRCA1, 2 as well. You have the occasional gene like PALB2 going in the opposite direction. Importantly, Neil, we don't have FDA approval of niraparib in the hormone-sensitive setting yet. We might expect to see it soon, but we don't have it yet. So at the current time, it still would be considered off-label use to use any PARP inhibitor in the hormone-sensitive space. These are the other trials that we'll read out soon. The TelePro-3, which is hormone-sensitive again, biomarker selected with the addition of talazoparib to enzalutamide. That study has not read out yet, but will be the next one. Then there are several others in the pipeline. Moving to an unexpected result of the combination of radium plus enzalutamide. This was the PEACE-3 trial. Patients with bone metastatic prostate cancer, first-line mCRPC. They were allowed to have received abiraterone in the HSPC setting, but that was only a small subset. And then they were randomized to enzalutamide by itself or enzalutamide plus radium-223, given every 4 weeks for up to 6 doses. rPFS primary endpoint was met. And surprisingly, at least to me, overall survival was also met. That was a key secondary endpoint. The p-value needed to be less than 0.0034, and they just made it with 0.031. So the statisticians were all pleased, and so were the investigators, and we do have a survival advantage here. So this could be a possibility, although not specifically FDA approved, for any gentleman where you are considering enzalutamide in the hormone-resistant setting. You could consider adding radium-223 if there is bone-predominant disease. There was more fatigue, fracture, anemia, and neutropenia in the combination group, and these are known side effects of radium-223. Moving to lutetium-177, pivotide, textrazetan. We're not allowed to use brand names, so I have to say that whole thing. Radioligand therapy, what is a radioligand? So in this case, we are taking a ligand that binds to the PSMA receptor. That ligand is linked to a beta particle radiopharmaceutical agent, lutetium-177. This only enters into the cells that express PSMA, so we need a PSMA scan at the beginning before we enroll patients. This was the VISION trial in the second and third line mCRPC population. They were randomized against best supportive care, so there were no life-prolonging agents included in the control arm of this trial. The trial was positive for rPFS and OS and led to the initial FDA approval in the post-docetaxel setting. Now, subsequent to that, we're going to talk in a moment about the pre-chemotherapy trial. But in the VISION trial, dry mouth due to the expression of PSMA on the salivary glands is a side effect. There also is a mild degree of myelosuppression as well. Now, of course, when you have a post-taxane indication, you want to get a pre-taxane indication as well. So this was the pre-taxane trial, lutetium PSMA versus an ARPI switch. So these were patients that had received one and only one ARPI in the hormone-sensitive space. The randomization was 1-to-1, and importantly, there was a built-in crossover where the sponsor provided lutetium PSMA to the patients in the control arm, and 84% of patients in that control arm did in fact cross over. And what's important here is that the rPFS was met. It was a big magnitude of a benefit with a hazard ratio of 0.49. All the other clinical endpoints favored lutetium PSMA, but the overall survival was not any different. And one of the arguments that the authors made was this was because of the 84% crossover. Despite the lack of overall survival benefit, this was FDA approved several months ago, and now we have the option of using this prior to the receipt of docetaxel chemotherapy. Again, dry mouth is the main side effect here, with some nausea and mild anemia. Now, this is the one that's going to be presented in about 7 days at the ESMO meeting in Berlin. This is the PSMA addition trial. We're now moving into the metastatic hormone-sensitive space. The backbone here is ADT and any of the FDA-approved ARPIs, with or without the addition of up to 6 doses of lutetium PSMA for PSMA-positive patients. There is a crossover in this trial as well, so keep that in mind when we see the overall survival one day. But the primary endpoint here was not overall survival, it was rPFS. We have not seen the results. I do not know what they are, but we have been told, based on a press release, that the study was positive for rPFS. We don't have any numbers here or statistics. So we will find out next week what the magnitude of that PFS benefit was. And of course, the overall survival is still going to be underpowered at this time. One slide about promising agents. There are many here that I want to point out. There's at least 6 classes that I'm pretty excited about. We heard about capivasertib already. We have agents that inhibit other adrenal enzymes such as CYP11, which are involved in androgen synthesis. We have other ways that we can degrade the androgen receptor with PROTACs. We have other epigenetic targets like EZH2, which has been used in other diseases like lymphoma. We have a new target, which many of us have not heard about, B7H3, which we can use antibody-drug conjugates against. And now we have actually, for the first time, effective immunotherapies. These are the so-called bispecific immune engagers. Thanks very much.
Thanks a lot, Emmanuel. And just kind of curious, have you seen activity? I think I saw something, I don't know if it was ESMO or ASCO, with this B7H3 ADC. Do you see objective responses?
Yes, there's at least 3 of them. We are seeing objective responses. The toxicity is more reminiscent of a chemotherapy, so we have to watch that. But yes, we are seeing about 20 to 25% objective responses.
So trying to figure out what we're going to be doing about hormone-sensitive metastatic disease in the next couple of weeks. So my first fantasy, Emmanuel, is suppose you have a patient who's BRCA2 and PSMA positive. I'll start with Matt.
Well, they're almost all PSMA PET positive, so that would be the expected result. So I think I look at RLTs as anatomically targeting radiation to the tumor. When we're talking about other pathways, AR, PARP, you're biologically targeting the tumor. So if the data were comparable, let's say, I would favor the PARP inhibitor in that patient as the priority. I would not be comfortable combining those agents at the same time based on the lack of safety data.
Yeah, you wonder what happened in terms of the bone marrow in that situation. How much bone marrow suppression do you see just with lutetium, Matt?
I think, as Emmanuel said, it's relatively modest. It's sort of manageable, at least in the settings for which we use the drugs. I think it is a greater concern if you move the drugs up the line, right? We worry about late myelosuppression or persistent myelosuppression.
So, Emmanuel, here's a case. Patient is BRCA1, pretty unusual, I think, for prostate cancer. Maybe you can comment on that. With 2 vertebral mets on PSMA scan, underwent XRT, now on LH, RH, and enzalutamide with the PSA of 0. Would you, if you could, putting aside regulatory issues, would you add PARP inhibitor?
So in that scenario, I wouldn't. He's had a complete response already with the doublet therapy. I would watch him very carefully, wait for that first sign of PSA elevation in the future, and then we have multiple options for that patient. We have olaparib as a monotherapy. We would have also enzalutamide, talazoparib as an option as well.
So, and here are some of the, again, more from ESMO. We're going to see this PSMA addition trial, really interesting and super important. Also, we're going to see some data. There's another PARP inhibitor that's being tested in hormone-sensitive metastatic disease, saruparib. but I think that one maybe is going to mature a little bit later in terms of hormone-sensitive metastatic disease. So, Emmanuel, you had that great graphic up there, sort of putting the different mutations in different categories. But, from a clinical perspective, in terms of, you look at the patient and go, oh, that patient really is going to benefit from a PARP inhibitor. Obviously, BRCA1, BRCA2. First, your comments about BRCA1, why we see it so infrequently. But also, and you had in there RAD51B and RAD54L. You consider that as sensitive as BRCA?
Yes, but they're extremely, extremely rare.
So what are the mutations that we should be looking for and go, okay, yeah, BRCA. Those two, BRCA, what else?
So the great news is that these NGS companies are here to help us, and they're going to put that on their front page. If there's a companion diagnostic for a particular PARP inhibitor with a particular gene, they will call that out for us. So for example, RAD54L, as you mentioned, nobody's going to remember that. But if you do have the occasional patient that has this mutation, that front page of that Foundation Medicine or Guardant 360 or Caris report is going to say companion diagnostic for whichever PARP inhibitor is approved. In this case, it would be olaparib.
Question from the audience about ATM, Emmanuel. How sensitive is that?
Yeah, we have become unenthused about the sensitivity in ATM. Some of those patients also have a concurrent BRCA mutation, which is why they are responding. But ATM alone, we might consider experimental ATR inhibitors in those patients. The jury's still out. But PARP inhibitors, probably not very successful.
So, Matt, one person says in Europe, PARP is approved in prostate for regardless of HR status. Are there situations where you'd like to use it outside of BRCA and as it's approved in Europe?
So the key thing here in Europe, it's approved in all comers, meaning biomarker negative, no DNA repair mutation. I see that as an unusual choice of the EMA. I'd recommend testing rather than treatment of all comers. I'm not compelled by the strength of evidence to treat patients who are biomarker negative. There is a modest effect on our PFS. I don't find that sufficiently compelling to recommend such treatment for patients who are biomarker negative.
Yeah, that was kind of the way things went, and I think also in ovarian cancer. But in ovarian, Matt, they also have the LOH score. I guess some kind of quantitative compilation. Is anything like that available for prostate?
Not yet. I mean, the so-called BRCA-ness score,
right.
Sort of like, no. I mean, there could be a role, but I think you get most of the benefit from tier 1 of Dr. Antonarakis' list, particularly BRCA1 and 2.
So, Emmanuel, can you talk a little bit about right now, theoretically, again, putting aside reimbursement issues, how you're thinking about bringing in PARP? Would you go outside of niraparib if you could? And exactly how would you do it in terms of sequencing with the other therapies that the patient's getting, endocrine therapy, maybe chemotherapy?
So the likely first FDA approval, if it occurs, is going to be niraparib abiraterone. And it's likely going to be all 11 or 12 genes, but the main benefit is going to be in BRCA1 and BRCA2. So like we discussed before, this is going to require biomarker testing up front. A lot of these patients, all they have is a biopsy of the prostate gland, or maybe if it's a metachronous metastatic disease, the prostatectomy itself. So when we see that patient for the first time, in the initial consultation, we're going to start the ADT, we're going to start the ARPI, and one concern there is we're not going to have the BRCA information. And what if that ARPI happens to be darolutamide, which is what I'm doing in most of my patients, and then 4 weeks later, I get the BRCA result and it's positive. There I'm going to have a challenge because there's going to be no darolutamide-based PARP inhibitor combination, and then the choice there is wait until early CRPC and start the PARP at that point, or abandon the darolutamide, switch it to abiraterone prednisone, and then add niraparib.
Matt, any thoughts?
Yeah, it's a very important point, which I guess we'd like real-time tumor genetic testing or immediate tumor genetic testing. And I also don't like to defer the decision about the ARPI, typically doing that at first visit. But the rate of finding these mutations is relatively low. So for 9 out of 10 patients or 8 out of 10 patients, you're going to proceed with the plan as existed. And then the others you're going to struggle with how to pivot.
So, Emmanuel, what about somatic mutations? Any difference in responsiveness? Again, ovary, the brachysomatic, brachygermline, they feel like it responds equally. And why do you see so little BRCA1 in prostate?
Yeah, so in ovarian, breast, and pancreatic cancer, the BRCA patients are evenly split 50-50 between BRCA1 and BRCA2. In prostate cancer, it's very different. It's about a 9-to-1 split, with BRCA2 being 9 to 10 times more common than BRCA1. And also, germline BRCA1 mutations in men with prostate cancer do not seem to predispose to the risk of getting prostate cancer. So the germline BRCA2s increase risk, of course. Germline BRCA1s, most of the prostate cancers in those patients are sporadic. They're not related to the BRCA1. So there's something very interesting biologically going on there. Again, the BRCA1s, they will be sensitive, whether it's somatic or whether it's germline. I think that has been replicated from the other cancer types. There is one interesting thing about the somatic, though. One class of alteration is called a genomic deletion, where you have deletion of both copies of the entire gene. That never occurs in the germline because that would be embryonic lethal. But those patients tend to have extremely prolonged responses because they can't develop these reversion mutations.
That's interesting. So, Matt, here's a case, a 71-year-old man, metastatic CRPC, somatic BRCA1 mutation. Interesting. Disease progression after enzalutamide. What do you do next? Do you do PARP alone? Do you add in AR-targeted therapy, and which PARP?
Yeah, so I would either discontinue the enzalutamide and treat with olaparib, or if you wanted to, you could continue enzalutamide and add talazoparib. I would probably do the former. The ARPI switch has very limited activity, very low response rate, short response duration. It's been the losing arm of all the control group of a bunch of trials, so I don't have any enthusiasm for doing the ARP switch and adding the PARP. I would just add a PARP inhibitor.
Emmanuel, any comments on tolerability, toxicity of the available PARP inhibitors? In niraparib, again, I'm thinking back to ovarian cancer, that you see more thrombocytopenia. Again, how would you contrast the tolerability, toxicity of the available agents?
In my experience, olaparib is the least toxic, both in terms of the marrow and other effects. It does cause a little bit more nausea than the rest, but that can be ameliorated if you take it with food or with a light snack. But there's no question that talazoparib and niraparib have more thrombocytopenia, but also anemia requiring transfusions.
So I'm going to go on and talk a little bit about lutetium. And a question from the audience, Matt, how fast do you see pain control with lutetium? The person says, let's say severe pain, 8 out of 10. You give a dose of lutetium. What do you expect to see in terms of pain?
I'd be worried about that patient. I wouldn't count on PSMA lutetium to achieve an adequate pain response. So you're going to have to separately control the pain, understand the pain, consider radiation if it's being driven by a single anatomic site, and then add the PSMA lutetium. So we're trying to treat patients who are like asymptomatic or minimally symptomatic, and we're able to do that because of better imaging and such. But I would not rely on that to achieve pain response. And in the occasional patient with a lot of pain, I wouldn't expect to see a uniform, prompt improvement in pain.
Same thought about radium? Or you see pain relief?
I would say probably similar situation. I mean, there's certainly no comparative data. It's also the historical context is different, because the peak radium use, I guess, was at a time when we had few other options and was typically being used very late in patients who are more likely to be symptomatic.
Emmanuel, what about this combination of radium with androgen agent, as well as enzalutamide? Would you use it with any other? Would you use it with darolutamide? Are you doing that?
I would not use it with any other agent. We have to stick with the data. The challenge with the PEACE 3 trial is that the vast majority of those patients had just received ADT alone, and a small fraction had also received abiraterone in the hormone-sensitive setting. And nowadays, many of our patients that get to first-line mCRPC have received either enzalutamide or darolutamide or sometimes abiraterone, and also chemotherapy as well. In the occasional patient who has not received any of those, who makes it to first-line MCRPC with ADT alone or maybe ADT plus abiraterone, who would otherwise be eligible for enzalutamide and has bone metastases, then I would consider the combination.
So, Matt, obviously we want to see the data. I think you maybe can sort of anticipate, at least it's going to be positive. We'll see how positive with this lutetium and hormone sensitive. But assuming it looks promising, what are you thinking in terms of, you think everybody or specific situations?
I think if there's an overall survival benefit, I would be moved to use that as a very routine approach in that setting, particularly patients with a high burden of metastatic disease. If there's no OS benefit, we're going to be left with the same problem we currently face, which is what is the optimal sequencing of this. And I mean, to date, we're really looking at probably for an individual patient, for the most part, you're going to get your 6 doses of this drug at some point in your care, and then it's a matter of does the data move you to administer that therapy earlier.
Emmanuel, what are you thinking?
Well, I was thinking something very unusual, which is I was thinking about a patient that has a BRCA2 and a PTEN deletion and a positive PSMA PET scan and what I would do in that patient. And I think it would have to do with the magnitude of the rPFS benefit and the safety. But in general, I would say that the AKT inhibitor would probably not be my first choice in that setting because I suspect that the side effects would be the worst. I think with the BRCA2, that would always trump everything else, and I would want to use a PARP inhibitor. If you take the BRCA2 out of the equation, if I had to choose in a PTEN deficient patient between capivasertib and PSMA lutetium, I probably would go with the PSMA lutetium based on safety profile. There's one other comment I want to make here. You know, the PSMA lutetium in this setting, the trial was up to 6 cycles, but it's very unlikely in real life that we're going to be using all 6 because you get a diminishing return as the target goes away. And my suspicion is that after 2 doses, maybe 3 doses of lutetium PSMA in these patients, the hormone-sensitive patients, PSMA target will disappear. And then what you're doing is you're just radiating the salivary glands, not the cancer. So I think many of us, even though the label will say up to 6, we're going to give 2 or 3 re-image with PSMA or Spec CT scans, and then probably withhold the 3rd, 4th, 5th dose, save that for later.
Matt, any clinical tips about lutetium? What kind of tolerability issues come up, even quality of life, convenience? What do you see in these patients?
Yeah, so I think the salivary gland toxicity is real, something you advise patients about. The drug's generally well tolerated. You do have to watch for cytopenias. One of the interesting observations is it's challenging for some patients because they don't like the self-isolation that's required immediately after treatment. That's particularly problematic for multi-generation families, granddad who lives with his small grandchildren, those sorts of things, 1 bathroom, those kind of scenarios. So those are things you need to talk through with the patients.
So I don't know how often this happens. We've been asking this question for a while too, Emmanuel. A patient who's potentially eligible with bone-only or bone-predominant mets, and I'm also curious how much nodal disease you can have before you wouldn't use a radium. But assuming the patient's eligible for 2, what do you prefer?
Right, so for radium, you have to have lymph nodes less than 3 centimeters in diameter and visceral disease less than 1 centimeter in diameter and bone-predominant disease for the rest. I think a patient that has a urinary incontinence or an indwelling Foley catheter or a suprapubic catheter or is in a nursing home patient where the hot urine would be a problem for the staff and the patient's family members, I would avoid lutetium PSMA in that patient for the reasons that Matthew mentioned. But again, those patients are not so common. I don't think the presence or absence of pain would be a major factor to distinguish the 2 because the pain relief is relatively delayed with both of them.
So one final question, Matt. I've always wondered about radium outside of prostate cancer. I mean, you do see bone-only mets in breast cancer and other diseases. Has it been looked at, and do you think it would be effective?
Very limited, I think, studies in other diseases. It really requires that they're osteoblastic, not osteolytic metastases, so that's the big driver behind its investigation and approval in prostate cancer.
Interesting. All right, we're going to move on and talk about colorectal cancer. Thank you so much.